The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. In parts 1 and 2 of this episode with Drs. Newcomer and Fields, we learned about all aspects of the assessment and treatment of cutaneous melanomas. Now, on to part 3 of this episode focused on non-melanoma skin and soft tissue tumors.
The chapter that we're talking about also includes some other malignancies, and so I wanted to quickly review those. As always, please jump in if you have any thoughts about these prompts, but I'll ask you some quick questions, and we'll see if we can touch on the most high-yield topics for trainees. Now, basal skin cancer is the most common cancer in adults in the United States, with squamous cancer sort of taking over among patients who are immunosuppressed. Nowadays, many basal and squamous tumors of the skin are treated by dermatologists, with Mohs surgery being commonly performed in tumors of sensitive areas. How often are you involved in the care of folks with basal and squamous skin cancer?
A fair amount. The surgical oncologist will be presented with a lot of patients that, say, for whatever reason, present with a locally advanced tumor that may be more invasive, that may not be conducive to a dermatologist's procedure in the office or a Mohs procedure due to size, depth. You can kind of think of squamous cell and basal cell cancers as more locally aggressive but lower metastatic potential than melanoma. So a lot of times they can grow big, but they can be destructive and require resection and then reconstruction with skin grafts, flaps, things like that. There is also a subset of squamous cell cancers that have higher risk features that sometimes you might consider sentinel lymph node biopsy. These would be poorly differentiated tumors, like you mentioned, tumors in immunosuppressed patients, rapidly growing or evolving tumors. And then, of course, a fair number of patients, like in melanoma with squamous cell cancer, may present with nodal disease at the time of diagnosis, where a surgeon would be involved for consideration of lymph node dissection. Although I will also say that in the current era, we also see the effect of immune therapies in squamous cell cancers. So this concept of neoadjuvant immune therapy is also becoming in vogue in squamous cell cancers.
And to quickly review some relevant embryology, our melanocytes are derived from the neural crest. There is another cutaneous tumor that comes from neural crest-derived cells. That's the Merkel cell cancer. There's a relatively recently described double-stranded DNA virus that's associated with that malignancy, the Merkel cell polyoma virus, which I think is important to highlight and keep in mind for our surgery trainees. But more importantly, when it comes to management of these tumors, can you just quickly talk about when you choose to do a sentinel node biopsy for Merkel cell tumors and when radiation is appropriate in the adjuvant setting for those patients?
Yeah, so Merkel cell is a little bit more of a rare or uncommon tumor, so we don't have an MSLT type trial in Merkel cell, and nor will we ever. What most surgical oncologists would say is, for a newly diagnosed Merkel cell cancer, because oftentimes they happen in the setting of immune suppression and they can have a variable pattern of aggressiveness, but it's hard to know starting out, we usually would stage those patients with some sort of imaging and consider sentinel lymph node unless we weren't going to act on the sentinel lymph node. So sentinel lymph node biopsy in Merkel is more of we'd consider it in everyone. The difference between Merkel cell, or one key difference I should say between Merkel cell and melanoma, is that Merkel cell is a highly radiosensitive tumor. So we commonly will use adjuvant radiation either to the nodal basin or the primary tumor site in higher risk patients. So it's utilized not infrequently. And as you mentioned, if we take all the Merkel cell patients, about half of them will be virally associated. So they're caused by Merkel cell polyoma virus that's prevalent everywhere in the environment. But if it happens to insert in the wrong spot, it can be an oncogenic virus or not, and be responsible for that. But because of that, it expresses viral antigens and is highly antigenic. The other half of Merkel cell cancers are, like melanoma, UV derived, so they also have a high tumor mutational burden. So Merkel cell is also highly effectively treated by immune therapy, even more so than melanoma. It's almost the best tumor in terms of response rates to immune therapy because of those two features.
Let's do 2 more quick case presentations to highlight a couple of other tumors that are mentioned in the book chapter. First, a 55-year-old female presents with a 3-centimeter lesion of the right shoulder, and biopsy demonstrates dermatofibrosarcoma protuberans, DFSP, without a component of any high-grade sarcoma. What kind of resection margin would you recommend for that patient, and how do you counsel your patients about local recurrence risk and soft tissue coverage?
Sure. So DFSPs are not uncommon tumors. I like to think of them as kind of abnormal scar tissue. They can be very locally aggressive and recurrent tumors, but low metastatic potential, with the exception of, and this is something you ask your pathologist, is there any fibrosarcomatous transformation? Do they see a true sarcomatous part on a biopsy? And if the answer is no, then it's a classic DFSP that is likely, again, one of these more locally recurrent phenomenon. The reason is they're not perfectly sphere tumors. They tend to have these infiltrating papilla or protuberans, and that's part of the name, that infiltrate into the surrounding soft tissues. So the goal is microscopically negative margins, but to do that, you generally need 2 to 3 centimeters of gross negative margins. Now, DFSPs, which they do commonly occur on the scalp, forehead, that sort of thing, are effectively treated by Mohs. So Mohs surgery is an option and a referral for a patient in that type of area. Otherwise, it's 2 to 3 centimeter margins. If you can close it primarily, great. If you can't, oftentimes we'll delay the closure until margins are back, say with a wound vac or other type of device. Once margins are confirmed negative, then appropriate soft tissue coverage. Oftentimes, if you have a big DFSP, you may get imaging of that area to see how deep it invades and make sure you're not missing some component. And then the follow-up is similar to any other skin or soft tissue patient, where you follow them clinically, sometimes with imaging if you're worried about something that you can't get good on clinical exam in a challenging area.
And then finally, another case, a 65-year-old woman with no history and no family history presents to the ED with a 6 by 4 centimeter mass in her right thigh. And you're worried that this possibly could be a soft tissue sarcoma. It's solid on CT with some internal hemorrhage and necrosis. An MRI is pending, but as is often the case, it's going to take a little while. Nowadays, how do you usually get a tissue diagnosis for this kind of patient?
Yeah, so I would say the paradigm is you really want to get a good biopsy, because there's so many types, over 100 types of sarcoma, and the type defines the treatment, both in the neoadjuvant setting, especially whether or not you're might use a systemic approach versus neoadjuvant radiation followed by resection. So there's a lot of nuances. You want the diagnosis before you consider removing the tumor, and you want the biopsy to give you enough information to subtype the tumor, but not interfere with your planned resection. So an FNA biopsy is generally not adequate. You really want the architecture that you can get on a larger piece of tissue. Before the techniques were more widely available, an incisional biopsy may be advocated. These days, a core needle biopsy that's planned with your radiologist with respect to your potential planned resection, meaning let's say it's an anterior thigh mass, you want to have your needle biopsy put in a place that's going to be then incorporated in your ultimate incision to reduce the chance of spreading within that area definitively. It's a low concern with the needles they use now, but we always talk about it. And a core needle biopsy will usually give you enough tissue and the architecture to subtype that sarcoma. Although an incisional biopsy is not wrong, you can imagine if you go digging into a tumor with an incisional biopsy, you get things like bleeding and infection that could affect things, and you create a larger incision that you then have to plan to incorporate. So I would say the starting point is a core biopsy.
And for this patient, say that biopsy is obtained and the result is a tumor that I think trainees should be familiar with, an undifferentiated pleomorphic sarcoma, perhaps the most common in somebody who's presenting with this sort of clinical presentation. If this is a local resectable tumor, again, 6 by 4 centimeters, what is the multimodality treatment that you would recommend for that patient?
Yeah, so then, this patient's going to be at risk because of that nature of that tumor of metastasis. Typically for a sarcoma, pearl is, they like to metastasize to the lungs. So a good staging chest CT would be indicated. And then when you're talking about treatment, these are typically a tumor when it's that size is going to benefit in terms of local recurrence and outcomes of having radiation as a part of their treatment. So now the question is, well, do we do that before or after? And generally, planning it in the neoadjuvant setting reduces complications afterwards and allows the radiation oncologist to plan better when the tumor's there and do all the volumetrics and radiation planning for effective radiation therapy. That would certainly be magnified and almost mandated if this tumor was abutting major neurovascular structures, that sort of thing. But oftentimes sarcoma resections are done in conjunction with plastic surgeons, peripheral nerve surgeons, vascular surgeons, because of the nature of where they're located and what they may or may not involve.
Well, thanks again, Dr. Fields, for being with us today. We got to have a great conversation about melanoma and also a whirlwind review of some other skin and soft tissue tumors that are relevant to general surgery residents. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode. In the show notes, it'll be available. And also a full review of skin and soft tissue tumors can be found in the Washington Manual.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.